Hi guys, we're going to talk about anxiety and obsessive compulsive related disorders with the understanding that all of the disorders we're going to talk about in this chapter, in this lecture, are going to have anxiety as an underlying cause. So let's just get started here. So when we think about anxiety, this is a normal response to stress and a common human experience. I think we all have experienced anxiety at one time or another. It is that reaction to worry, to fear, to the apprehension, uneasiness from either real or perceived threats. Anxiety is also necessary for everyday life. This is called healthy anxiety and can motivate people to make and survive change. It prompts constructive behaviors. For instance, healthy anxiety for studying for an exam, arriving on time for a job interview, or even preparing for a presentation. As stress becomes more persistent or excess, then it interferes with daily functions of life. Everyone is going to handle stress differently. One may thrive in a situation that creates great distress to another. So we've stated that anxiety that persists or is excessive does interfere with daily functioning. This is why feelings of anxiety occur at inappropriate times or sometimes in situations. As a person's anxiety increases, there are physiological changes in the body. Early effects of anxiety result in increased blood to the heart, muscles, and brain, which increases the person's ability to function, think, and perform. This slide just shows the cycle of anxiety, and you can see there at the top of that middle picture, the trigger, right? Something is the trigger, and then our anxious thoughts begin. What will happen next? I can't do this. Only bad things will come of this. As those anxious thoughts manifest, then we have emotional feelings that kick in. Fear, anxiety, worry, dizziness, and then again, as those continue to escalate, physiological responses start occurring, and we've talked about elevated heart rate, some GI distress, dry mouth, dry throat, right? We're breathing a lot faster, a lot shallower, and then we start having behavioral responses. That's when our fight or flight may kick in. We may fight with anger, frustration, maybe some aggression, or we may flee, right? We may flight to just try to avoid the situation. But it's this ongoing circle that kind of happens, and it's that cycle of anxiety. So there are 4 levels of anxiety according to Peplau's theory. We can talk about mild, moderate, severe, and panic. So with mild anxiety, this is normal, can be very normal. It occurs every day. It makes us more aware of our surroundings and can really give us better focus. When we think about physical symptoms of mild anxiety, we may see a slight discomfort, maybe some restlessness, or some irritability. So what do you think a person with just mild anxiety might be doing? You may see some nail biting, some foot or finger tapping, or they may become just a little more fidgety. As that mild anxiety turns to moderate, or we step up into that moderate anxiety, then our senses become somewhat hindered. Seeing, hearing, maybe grasping information may be lessened. Maybe we have some selective inattention. Our thinking clearly may be hampered, but problem solving and learning can still take place. So we may not think as clear, but we can still problem solve and learn from what's going on with the situation. But it may not be as optimal. So with moderate anxiety, you may notice increased heart rate, respiratory rate, maybe a little sweating or GI discomfort. So as we moved up to that moderate anxiety, now our we may be pacing more nervously. Now the tapping that we had in our mild may now become more banging in nature. So we just need to remember that mild or moderate anxiety levels can still be constructive, and they are signaling that something in our life may need attention or we feel might be dangerous. Severe anxiety. This is this particular one. We have many scattered details. Now our thought processes aren't smooth at all. At this point, we're really unable to learn or problem solve at this level. Some of the characteristics that we may see include just that feeling of dread. Maybe some confusion sets in, or we just feel dazed. Just really kind of a pure sense of doom. Behaviors become aimed at reducing or relieving that anxiety. So this person may be sweating, short of breath, complaining of chest pain. They may be yelling or threatening to attempt to alleviate the fear of impending doom. Panic is the most extreme. We may have all seen someone in a panic level of anxiety. They don't recognize really what's going on. They may be running around, shouting, screaming, which eventually is just going to lead to exhaustion. Some of the characteristics you may see with this person is really that inability to speak, or speech could be unintelligible. They may feel numb, complaining of chest pain or shortness of breath. These people are truly terrified, and they just want to escape the fear or the danger that they are experiencing. So just as a recap here, we can see our anxiety levels on that picture there, and it can be compared to a speedometer on a car. During a low level of anxiety, an individual's very laid back, they're relaxed, but as that anxiety increases to moderate, the individual's ability to perform and function increases as some anxiety motivates. If the anxiety continues to increase, then the person becomes overwhelmed and the ability to function deteriorates. And then this is when our panic begins. And when that anxiety becomes maladaptive, causing distress in the person no longer can function or cope. So let's talk a little bit about obsessive compulsive disorder. OCD is precipitated by anxiety. It can be diagnosed in children and in adults, and it usually occurs when one experiences obsessions, which are persistent and recurrent thoughts or urges that are unwanted and become intrusive. So if you can think about obsessions are those thoughts. So although individuals with OCD know that their thoughts and behaviors don't make any sense, they're compelled to do them and they're unable to stop. Compulsions are those repetitive behaviors that are performed by the client to lessen or prevent that anxiety that's been brought on by the obsession, right, or the thought. So these obsessions and compulsions become time-consuming. They can interfere with that patient's ability to perform just those daily tasks. So remember, obsessions are recurrent or persistent thoughts. So here are some examples. Harm or harming someone else, fear for safety, cleanliness or germs, fear of forgetting something important, worrying about tidying or neatly arranging things. Where compulsions are the repetitive behaviors. So obsessions are our thoughts, compulsions are our behaviors. So checking there and rechecking the door if it's locked, ritualistic order for hand washing, repeating specific words or phrases. So if you're a Big Bang Theory fan, right, you know Sheldon has those obsessive and compulsive thoughts when he has to knock on the door, right, and he has to say penny every time, right? It's just repeating those specific words or phrases. Let's see, counting objects, repeating an activity or a specific number of times. And again, I think of Sheldon with that one as well. So how do we distinguish between anxiety and OCD? All anxiety disorders share a common feature or clinical presentation: apprehension, nervousness, restlessness, irritability, really just anticipating the worst result. They're watching for what causes that anxiety, and they're trying to avoid any of that cause. Some of the physiological manifestations you can see there, we've already kind of hit on. Increased heart rate, sweating, fatigue, GI disturbances, sleep disturbances, right? When an individual is exposed to a fear, the amygdala and the hypothalamus cause changes in that hypothalamic pituitary adrenal axis, which results in hormone release, leading to a survival response. So some of the specific anxiety disorders that we're going to talk about, and these are listed in order of life cycle emergence. So the first one is separation anxiety disorder, and this is a developmentally inappropriate level of concern over being away from a significant other. This happens when clients experience excessive fear or anxiety when separated from an individual they are emotionally attached to. Typically, this happens mostly in kids, but it can be seen in adults. For kids, this is a normal part of development that may begin about 8 months of age and usually resolves by 18 months of age. But if the patient is developing inappropriate levels of separation anxiety, it can really affect future relationships. Adults may have difficulty with romantic relationships. They're usually unlikely married, or they're unmarried, sorry. They tend to worry, and they tend to be very shy and uncertain. Selective mutism is a consistent failure to speak in specific situations where speaking is expected. They're not able to speak during school, even when spoken to, and this can really affect achievement academically or societally. It interferes with regular communication. And then the next one, there's phobias, and this is experiencing just a marked fear and anxiety upon exposure to certain objects or situations. This can include phobias to animals, maybe to heights, or even the sight of blood. Social anxiety is just as it sounds, experiencing marked fear and anxiety upon exposure in a social situation. So your thoughts kind of ruminate on being embarrassed or humiliated, rejected, or maybe even offending others. These patients can really experience distinct and extreme periods of physiological and psychological hyperarousal. Panic attacks usually are unexpected and occur with no real apparent reason. And many times we see this as a person arriving into our ER. They're complaining of chest pain, no other complaints, no other medical cause. That could be considered a panic attack. They may have all of the signs of myocardial infarction, standing on the chest, impending doom, but really what they're experiencing is a panic attack. And then that last one there is agoraphobia. Agora meaning open space, phobia meaning fear. And again, it's just that intense anxiety or fear about being in places or situations from which escape may be difficult or may be embarrassing. So this could include closed spaces such as elevators, open spaces such as parks, or even leaving their home. The result of this disorder is avoiding the situation or requiring others to navigate the situation. Obsessive compulsive disorders. Obsessive compulsive disorders and related can share common clinical manifestation. It's usually the presence of those obsessions and or those compulsions. And we've kind of talked about examples of those. So all of these disorders are obsessive compulsive disorders. They are also anxiety driven. So body dysmorphic disorder, hoarding disorder, trichotillomania disorder, and excoriation disorder. And we're going to talk about each of these. So the first one is body dysmorphic disorder. This is that persistent preoccupation with perceived defects or flaws in one's appearance. So you see them constantly checking themselves in the mirror, excessively grooming themselves. They like to seek reassurance about their looks, and they are very much perfectionists. So when I think about body dysmorphic disorder, I think of Michael Jackson, right? He was never happy with his appearance and always changed it. They usually have a very normal appearance, but they don't see themselves as normal. So then you start seeing the obsessions and then the compulsions of following through with those changes. Changes could include skin, hair, nose, or weight. And this disorder is often kept very secret for many years, and they often don't acknowledge comments or reassurance from others that they do look okay. And so you can see here, right, young Michael Jackson to the Michael Jackson prior to when he passed away. And you can just see kind of how normal he looks, and then change in skin color, change in nose, not a lot of change in hair until that third picture, but again, more change in skin color. So you can just see how the changes were happening. Hoarding disorder is just that overaccumulation of stuff that really doesn't have a lot of value, and it starts to really interfere with their lives. And so you probably all have heard of the TV show Hoarders, right? This was just a picture I grabbed off of the internet. Clearly just a lot of accumulated stuff. And that clearly looks like it's probably interfering with just their daily life. As far as trichotillomania, this is demonstrating patterns of ritualized behavior defined by serially and intentionally pulling out one's hair. This often occurs in children and can begin as early as 1 year of age. Hair pulling can be on the head, but it could also be eyebrows, eyelashes, pubic hair, axilla, and limbs. Behaviors are typically triggered by boredom and or anxiety, and usually the behavior is the result of the behavior or just trying to reduce that tension, right, that anxiety, and it leads them to a form of gratification and pleasure and sense of relief. So you can see here the top of this young person's head, maybe old person's head, I'm not sure, right? They have just pulled out all that hair to the point where they've even got a little bit of excoriation going on, where they've got some sores in there where they've pulled those hair follicles out. And then excoriation is a pattern of behavior defined by recurrent picking at their skin, resulting in some lesions. It's usually commonly found on the hands, face, arms, or multiple body sites. It's typically done with fingers or fingernails, but you may also see it performed with nail cutters, tweezers, or even their teeth. So you can see this young lady's face where she's just picked it raw. She's got some bleeding areas there. And again, she could have done it with her fingers or fingernails, or maybe she found some tweezers or nail clippers to do it. So let's get into a little bit about the interprofessional team when it comes to anxiety and OCD disorders. Integrated and collaborative care is a client-centered approach, and services should focus on improving the client's care through ease of accessibility, collaboration, and quality across healthcare systems and specialties. Primary care becomes the entry point of healthcare services, many of which are traditionally only available for clients after a hospitalization. Some of the treatment we can think about, the first one are the first set of treatments are non-pharmacological treatments. So we're not using medications at this point. We're trying to treat them non-pharmacologically. So treatment of anxiety-based disorders and OCD-related disorders are generally treated with a combination of psychotherapy, which is our pharmacological treatments, health practices, medications, and complementary integrative approaches. So psychotherapy is that talk therapy. It's really focusing on any specific anxiety. Cognitive behavioral therapy combines cognitive therapy with behavioral therapies, and this could include restructuring, psychoeducation, breath restraining, and muscle relaxation. The cognitive model of anxiety is based on the premises that people with these disorders really overestimate the danger of situations and underestimate the ability to handle it. So patients are taught to monitor their thoughts before the anxiety response, learn to challenge the thought, and then replace the thought with realistic approaches. Cognitive therapy, you can see, is similar to CBT, and then exposure therapy we talked about a few weeks ago, right? That's when it's anxiety with something that they need just more exposure to. So we're going to gradually expose them to whatever they're fearful of or whatever creates the anxiety to make them more comfortable with it. I think the example I had done previously was the spider. Support groups, complementary integrative approaches, and lifestyle management are also more non-pharmacological treatments. You can see the complementary integrative approaches is therapy that focuses again on relieving that anxiety in specific situations. So relaxation techniques, deep breathing, guided imagery, right? What can we do to try to relieve that anxiety? And then lifestyle managements, right? Just making better choices, nutritional choices, exercising, avoiding excessive caffeine or substance uses. Pharmacological treatment, we can think about our anoxylytics, which are our benzos or non-benzos. SSRIs and SNRIs are essentially medications used to treat OCD. So we're going to really focus on just our anoxylytics. So our anoxylytics are benzodiazepines. When we think about the mechanism of action, we can think that they are a CNS depressant. They are an enhanced inhibitor effect of GABA, and they act on the limbic system, meaning it relates to perception and expression of emotions. So what are some of the therapeutic uses? We can use them for anxiety and anxiety-related disorders. They can also be used for seizure disorders and acute alcohol withdrawal. When we're thinking about our non-benzos, buspirone is the one that comes to mind that we'll focus on. And mechanisms of action for buspirone reduces the anxiety by binding to serotonin and dopamine, increasing that norepinephrine metabolism. This one does not bind to GABA like our benzos do. Therapeutic uses is usually generalized anxiety disorder. So let's focus on benzos. Adverse reactions, interventions, and teachings. Some of the adverse reactions we're concerned about if they're not on a correct dose or they're not taking it appropriately. Drowsiness, slurred speech. They may have difficulty recalling some events. If they have any confusion or anxiety, those are considered paradoxical reactions. Hypotension, tachycardia, respiratory distress. The benzos can build a tolerance for our patients and some physical dependencies, so we have to just be mindful if we're prescribing those medications and making sure that we're teaching about that. We also can't stop benzos just cold turkey. There will be some withdrawal symptoms that the patients will not enjoy. And then they can overdose. Overdose on benzos can include sedation, confusion, respiratory depression that may lead to cardiac arrest. So what are some of the interventions that we can talk about? We talked about drowsiness, slurred speech, right? So we need to monitor them for falls, assessing their memories, monitoring for those paradoxical reactions and their vital signs. Again, we're going to monitor for tolerance and dependency. If they do need to stop their benzos, it's going to be in a tapering dose. And then just watching for those withdrawal symptoms. And then teachings are going to be along the same lines there, and I'll just let you read those. The one I do want to focus in on is that we have to tell them they have to avoid alcohol consumption. If they are taking benzos and they are drinking alcohol, it's going to really accelerate or exaggerate what the benzo is doing for them. Non-benzos, look at those, some adverse reactions for our non-benzos. Paradoxical effects again, insomnia, anxiety, or restlessness. They may have some GI symptoms, dizziness, lightheadedness, or headache. So we're going to monitor for those paradoxical effects, fall precautions again, especially with our elderly population. And then just reporting those paradoxical effects, if they're having GI symptoms, have them take their meds with food, rise slowly from reclining or sitting positions to decrease some hypotensive concerns that may happen. Let's see, report headaches, and then teaching them about, can they take over-the-counter analgesics for headaches and what does that look like? So what's the nurse's role in our anxiety and OCD related disorders? We want to make sure we're giving equitable and sensitive care, being self-aware, client-centered. Prevention is huge, teaching, and then support. So let's look at each of those. This slide should actually look very familiar. It won't be the last time you probably see this information either. Self-awareness or self-reflection can foster continued learning. It can promote resilience and it can help reduce bias. So implicit and bias, if you have those implicit and biases as the healthcare provider, you need to find ways on how can I break that habit of implicit bias, and some strategies are listed there. Client-centered care, this should also look familiar to you. While occasionally it can be problematic, the presence of transference and countertransference could just put a damper on that nurse-client relationship. Prevention anxiety disorder is not preventable. All people that experience anxiety, it's considered normal human experience. So the focus is to try to help them see that trigger and then develop treatments for it, right? So that they can have a meaningful life, so they can have good relationships, satisfying work, personal growth, and healthy living environment. So what are we going to teach our patients? Education must be a primary focus, as it does improve our clients' belief in their own ability to overcome some of their challenges and accomplish tasks to achieve that individual goal. So being able to recognize their clinical manifestations and then utilize coping or strategies to manage that anxiety. So support strategies, like we talked about, the part of the nurse's role are support strategies. So actively listening, building that nurse patient relationship, therapeutic communication. We've talked about all of those things previously, right? Modeling, we can, if we see a patient experiencing a panic, right, sit down next to the client, you start breathing slowly and model that kind of calming effect. Our milieu therapy needs to be a place of healing, a space of calmness. We can talk about anticipatory guidance, anti-stigma messaging, right? Don't ever tell a patient that their anxiety is all in their head. It's real fear for them. What are their triggers? Helping them determine those causes of their worries. Let's see. The nursing process, we'll talk about assessment, right? We're recognizing cues. What are the manifestations that they're exhibiting? Are they mild manifestations? Are they at that panic level? What are some of the variables that are aggravating or alleviating some of those manifestations? And then maybe we're even figuring out, are there any physiological causes that might be creating some of this anxiety? So when we're assessing a client for anxiety, it's critical to explore their relationship with anxiety over the entire lifespan. If it's an elderly person with anxiety, talk to me about how you've had anxiety from the get-go. So this information on this slide just really assists the healthcare team in understanding the extent and level of anxiety being experienced by the client, as well as just determining if those manifestations of this disorder are resulting in an increased risk to harming themselves or harming others. So we've done our assessment, we've collected our data, now we need to analyze those cues and try to come up with a hypothesis. Obviously, safety is always first. Clients that are diagnosed with anxiety or OCD can be challenging when we're first trying to analyze those cues because many of their symptoms appear somatic, which are very common with our physical illnesses and also with our mental disorders. So a lot of times we've got to eliminate what's going on physically to try to figure out that this is an anxiety problem. So after we've assessed, after we've analyzed, we can plan some of our goals, generate some of those solutions. Remember to create this plan in collaboration with the patient. They usually don't require an inpatient admission, so we may need to send them to some community-based interventions. And then you can see that last little blip there as an example. Remember, our goals always have to be SMART. And then we're going to take some action. We're going to do some implementation. So we have to implement the least restrictive invasive intervention to address our patient's concerns. And that means therapeutic communication, right? Talking them down, controlling the environment. Maybe we're going to give them some medications if they're escalating to that panic. And then the very least or the very last thing or restrictive thing that we would not want to do is apply those restraints unless absolutely warranted. And then we're going to evaluate the outcomes. Did what we do worked? So evaluation is that opportunity for the nurse and the members of the healthcare team to consider how did our patient respond to the interventions? Were the interventions effective for them? So then if it was, great. If it wasn't, then we can update and evaluate based off the responses that we did get. And that concludes anxiety and OCD. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.